Thank you for coming out. I'm Dr. Solomon.
And I'm Dr. Narciso.
We're a couple board-certified general surgeons in the Kansas City area. We specialize in bariatric surgery or surgical treatment of obesity. We're a little unique in our practice. We don't utilize nurse practitioners or physician's assistants. We actually do all of our procedures together. And so if you're my patient, he's assisting me, and vice versa. If you're his patient, I'm assisting him. We found that it makes us work a little bit quicker, but also you have two sets of board-certified hands and eyes on you at all times. And so we found that our outcomes have been pretty good with the way we've been working, and so why mess with it? So
yeah, you get one of us, you get both of us, and we know each other's patients, so if there's a problem, we know what's going on.
So today, a little information gathering session. We're going to talk a little bit about the etiology or causes of obesity and being overweight. We'll show you some of the data, how diet and exercise, while everybody thinks it's fantastic, doesn't really work very well long term. And then we'll talk about medical and surgical therapies of it, and then we'll go from there.
Well, how do we measure obesity? One of the most common things that you guys have probably heard about is the body mass index, and that's basically, what we do is we look at the weight in kilograms divided by your height in meters squared, and that gives us a number. It's a general number that we use, we look at as surgeons. It's not the end-all, be-all. If like, say a football player, a linebacker, for their height and weight, they might be considered obese based on their numbers, but they're very lean. They have very little body fat, so it's a number that we use as a guideline. So there are different degrees, different numbers that we look at, and really obesity kind of starts right here with a body mass index of 30, and actually they call overweight body mass index anything greater than 25. So as people get heavier, the BMI goes up, so you can see that there.
And as you can see on this slide, in America, we're winning the race of being overweight. This is overweight. This is not obesity. Overweight, as Dr. Narciso said, anything greater than a BMI of 25. Once we start getting into obesity, a BMI of greater than 30 and above. The question is, why are the nations that are most developed winning the race? And we'll get to that when we talk about some of the causes and things. You can see in China, only 15% of people are even overweight, and most of that can be postulated that it's due to they all ride bikes, they eat small portions, and it's just a lifestyle thing.
Yeah, they have a very active lifestyle. And this is here in America, this is a problem that is growing. It's expanding. 3 in 5 Americans are either overweight or obese. That's a body mass index of 25 or higher. And just in the past 20 years, the obesity rate has kind of doubled. Okay, so just to kind of put everything in perspective, 300,000 premature deaths per year, and this number is actually going up, compared to 400,000 deaths per year from smoking, and that number is going down because of awareness and that kind of stuff, and 90,000 deaths per year from a combination of both colon and breast cancer. So as you can see, this is a number that's very high, and it's going up. It's increasing.
What comes along with being overweight? We all know that there are things called comorbid conditions, things that can be attributed to obesity. You have a 55% increase in death. That's what mortality is. 70% increase in heart disease, needing a bypass and things of that nature. 75% increase in stroke, and then the big one, the hot button topic in today's day and age, is diabetes. There's a 400% increase in type 2 diabetes mellitus with being obese. If you're a 25 to 30-year-old male, you have a 12 times increase in mortality versus your normal weight counterparts. That's a pretty staggering number.
So speaking of comorbidities, as Dr. Solomon has mentioned, things like diabetes, of course, that's the first one we mentioned. And diabetes itself has its own host of other problems that can occur as a result of having diabetes. But high blood pressure, lipid disease, heart disease, sleep apnea is another big one. People, have difficulty sleeping at night, wake up a lot of, really sleepy during the day. Asthma, reflux, gallstones. So there's a lot of different things that can go along with it. Blood clots in your legs, skin infections, venous stasis, and even some cancer.
And also the psychosocial aspect of it. There is an increased propensity for depression and things of that nature as well. Low self-esteem, decreased libido, uncomfortable in public. A lot of people avoid going out in public because of their obesity. And it really is the last bastion of discrimination. How often do people have to buy 2 plane tickets? Or I'm a big football fan, if you go sit in a stadium with bleacher seating and the numbers are stamped on the bleachers, they only give you 16 inches for each seat. 16 inches is only that wide. So that's pretty tough. And we see it all too often in society.
A lot of money is spent in America on obesity-related issues. Medical bills, people spend a lot of money on weight loss services and products and different things to try to help lose weight. There's a lot of time off of work, a lot of productivity issues, and money lost as a result of that. And what it boils down to is about 9.1% of the national medical cost, which is huge. That's an enormous number. So it has a very large impact economically.
So what are some of the causes of obesity? Well, we actually see it on the high and low extremes of income more predominantly. People of low income, cheap foods that are unhealthy, tend to increase your caloric intake. If you're extremely wealthy, you're going out to lavish 5-course meals every night at the Capitol Grill, eating big, fatty, greasy foods. We also see some people who have difficulty with coping mechanisms, stress, things like that. You get stressed out, you eat for comfort. There's also, we're a society of convenience. We're a very technologically advanced, country. We have moving sidewalks, elevators, escalators. You can do everything from your computer nowadays. A lot of TV watching. So our activity is significantly decreased. Now you can see it in children. Children today, they want to play their PlayStation instead of 40 years ago, is go outside and play on the jungle gym. And so it's changed a little bit, and that leads to decreased energy expenditure.
We're going to move on to treatment, and we always talk about the conservative therapies first. That's what's always tried. So diet, the first thing you think about when you talk about wanting to lose weight is one of the first things is diet. Try to reduce the number of calories that you take in. So you start looking at the calories on the labels and try to decrease the amount. And really, there's really a good initial weight loss with diet. And we'll talk about this with all the other modalities. It's not something that tends to be something that patients can continue on and keep weight off. It's not very durable. There are different types of diets, low-fat diets, low-carb diets. I don't want to talk about this too much.
Most people have tried them all and unfortunately failed, and we just know that. By the time you're here to gather information, I'd say greater than 95% of people have tried all the different conventional diets, Weight Watchers. They've tried even medications from their physicians, phentermine, things like that, which we'll talk about here in a minute. And the ultimate reality is we know that diet and exercise, unfortunately, for the large proportion of people, does not work.
The big issue is compliance. People have a hard time sticking to a diet. If you were on the grapefruit-only diet and that's all you had, you could see where you would want to eat some other foods. So it's difficult. In general, low-fat diets are better than low-carb diets for weight loss, but again, it's a very difficult thing from a compliance standpoint. How do you stick with the diet? That's the most difficult thing. So they're good for short-term weight loss, but not very good for long-term weight loss. Important for maintenance and that type of thing, as long as it's a well-balanced diet. But
This slide just kind of shows some numbers. 30 minutes of strenuous exercise, you're going to burn about 300 calories. To go reward yourself, eat one candy bar. Boom. You've just done away with all the benefits of that exercise. It's pretty easy to eat one candy bar. I know I crave them every now and then. You're just going to do it. In order to lose 1 pound of body weight a week, you have to cut out about 525 calories per day. That's a significant caloric deficit to sustain long term. So
There are some other treatment options. We talk about behavioral changes. Really, this is one that requires someone who's really highly motivated. But not only the patient has to be highly motivated, the counselor has to stick with the patient through all that as well. So it has to be that kind of relationship. We mentioned sleep here as well because sleep is a behavioral thing, and ideally patients are going to get less than 6 hours or more than 9 hours to get between 6 and 9 hours of sleep. Anything less than that or more than that is actually associated with an increased body weight.
So I briefly mentioned medications that patients have tried with their physician. They act in 3 different ways. Centrally acting by impairing your dietary intake. Peripherally, meaning they impair your absorption. There's a product out there, Ally. You take that, it doesn't allow you to absorb your fats, and so you eat and you run to the bathroom and have a greasy diarrhea bomb. Most patients don't like that long term because I don't know anybody that likes explosive diarrhea. And then you get medications that increase energy expenditure, such as phentermine, things like that ramp up your basal metabolic rate, so you burn more calories. And that has some effect, some efficacy, but there are some other things that come with that, like you get the yips and some other issues that go with that. So while diet and exercise is the first line of therapy, and then you kind of broaden your horizons into medications and see how that works, ultimately patients unfortunately don't do very well with all those modalities, and that's why they seek out this information.
The bottom line on this slide is we talk about all these therapies that, the medication, the diet, the exercise, behavioral type things. But regardless of what type of method that is non-surgical that is used, medical intervention, 90 to 95% of the weight loss is regained in 5 years, and that's staggering. That's a huge number.
And that's hard data. So we know of all comers, 90 to 95% of people are regaining all of their weight. So now we'll talk about surgical indications for weight reduction. BMI of 40 or greater than 100 pounds over your ideal body weight, that puts you in the category of, yes, you're appropriate for surgical therapy. Somebody who has a BMI of 30 with one or more comorbid conditions, sleep apnea, high blood pressure, diabetes, heart disease, joint disease, things of that nature. And patients who must have failed conventional diet and exercise, things of that nature, because that is the first line treatment. We don't jump right into surgery for anyone. And we also don't do children. You have to be an adult. There are a few centers in the United States that do pediatric, bariatric surgery, but those are still experimental because we don't know how they'll affect kids long term. So, as everything, insurance matters. Insurance coverage is improving for bariatric surgery. They have some hard and fast rules that we have to follow to get approval. Almost all of them require a few things. One, physicians supervise diet and exercise, weight loss attempts for a period of time, depending on the insurance carrier. Most require an appointment with a dietitian or a dietary specialist so that you can understand the differences between fats, carbohydrates, proteins, things of that nature. They almost all require you to see a psychologist just to make sure that you have coping skills. Remember, when we talk about bariatric surgery, it's a tool to help you attain weight loss. It's not going to do everything for you. And so they want to make sure that you have coping skills to be able to have a successful outcome.
There are some reasons we would say maybe you wouldn't be an appropriate candidate for the weight loss operation. Things like, if you couldn't have the general anesthesia required to undergo the operation for whatever reason, if it was a a heart issue or a lung issue that would keep you from having the operation. Things like, severe liver disease, if other things like alcohol abuse or drug use that was uncontrolled, uncontrolled mental illness. That doesn't mean, if you have a little touch of depression or anxiety, that's not going to keep you from having the operation. But if it's uncontrolled,
We're talking unmedicated schizophrenics, things like that are not candidates.
yeah.
And then we don't operate on patients that are actually currently pregnant, obviously. We would wait until that's done. So bariatric surgery falls into three categories. There are purely malabsorptive procedures, there are purely restrictive procedures, and then there are those procedures that combine malabsorption and restriction. Malabsorption means you reduce the amount of nutrients that you're absorbing from your intestines, thereby increasing weight loss. Restriction means we do something to prevent you from being able to take in as much food. A combination is obviously coupling those two. The ones with the stars, the adjustable gastric band, aka the lap band, the sleeve gastrectomy, and the Roux-en-Y gastric bypass, those are the three that are most commonly done today. We have chosen not to do the gastric bypass, and we'll explain why here in a little while. The two with the stars are the ones that we focus our practice on. And once again, we'll give you the pros and cons of all three of those primary procedures and kind of tell you why we arrive at our decisions the way we have.
So this is a schematic of the gastric bypass, which again we don't do. But here where the stomach is divided and a small gastric or stomach pouch is made. Coming down to it is the esophagus. Bypassing that portion of the stomach and small bowel. The small bowel is divided there. And the furthest part to that gastric pouch. And then you'll see the food particulate, what it does. It tends to it'll go down this way through this anastomosis, or the connection, and this way. And then the gastric fluid and the bile and pancreatic juices and everything will meet up with that about right here. And that's where digestion would begin. And so you can see where a large portion of this is being bypassed, thus being called a gastric bypass.
So you have the restrictive portion, the stomach is made smaller up top. You have the malabsorptive portion, you're bypassing that certain amount of small intestine. And so you do get excellent weight loss with the gastric bypass, we know that. What are some of the potential complications from the Roux-en-Y gastric bypass? Anastomosis means the junction where we put things back together. And those junctions can leak. They can stricture, meaning when they're healing, they can scar down and become narrowed, therefore preventing stuff from being able to pass through easily. You can get something called an internal hernia because we are rerouting things. The intestines can sweep underneath themselves and get twisted. You can get something called dumping syndrome, which is, for lack of a better phrase, exactly what it sounds like. You eat, you go to the bathroom, you have diarrhea. You get nutritional deficiencies. You have to take handfuls of vitamins and things like that. And so there are quite a few issues that can come about. Granted, it's a great tool. You're going to lose a significant amount of weight. 65 to 80% of your excess body weight will come off with the Roux-en-Y gastric bypass. But there are these potential complications.
And with these nutritional deficiencies, beyond having to take all these vitamins, it's going to your physician multiple times to get laboratory studies done to make sure your electrolytes are okay. We've even seen patients that have had to get admitted to the hospital for iron infusions and blood transfusions because there's a couple different ways that patients can get anemia. Things like inability to absorb iron, and then there's B12 in the stomach that when that doesn't couple with the food, the patients can get anemic from that. So Dr. Solomon talked about the different restrictive procedures, and we're going to start talking about the lap band now, which basically what the lap band is a band that goes around the upper portion of the stomach. You'll see here, basically the way the procedure is done, and we'll describe how it works, is this band goes in laparoscopically through a series of small incisions above the upper portion of the stomach, and then this port comes out and is implanted under the skin. The port is accessed with a needle, and by inflating or deflating that port, we're able to affect the inside diameter, thereby affecting the amount of food that is taken in here. And so you can see as that band is tightened, the amount of food, what's going through, is less. And so it's a restrictive procedure in that it causes a restriction at the upper part of the stomach, and it gives patients a sense of early satiety or a feeling of fullness. And so, you know, when the body gets that signal that, hey, I'm full, it sends a signal to the brain, and then you stop eating, you feel full.
That's the first question people ask whenever they come in and say, well, if I'm not able to eat as much food as I normally would, aren't I going to be starving all along? Well, that's what Dr. Narcissa was alluding to, is you don't have that sense of starvation, because eating a small amount of food in your newly restricted stomach pouch, pressing on the walls of the stomach, tricks your brain into thinking you're full. And so you'll eat a small portion and say, gosh, I'm full. And that's how you're not miserable with any of these restrictive procedures. So the lat band, it's 10 times safer than the gastric bypass. We're not rerouting anything, we're not cutting anything. It's fully reversible. You don't get any dumping syndrome. No stapling, cutting. It's quick operative time, less than an hour. We do it in an outpatient setting. You go home the same day. You do have a little discomfort, little more discomfort compared to the sleeve gastrectomy, which uses the exact same incisions, because we do implant that port on your muscle in your abdomen so that we can inflate and deflate the band. That being said, there is a foreign body inside your abdomen that can cause increase in scar tissue. This was more common with the older bands, but you could get erosion because it's pinching on the stomach. Over time, it could erode through the wall. It can slip and move up or down on the stomach pouch. And by the simple fact of having to stick a needle in the port all the time, if a needle is stuck in and the port is missed and the tubing is hit, it puts a hole in the tubing, then that necessitates further surgical therapy to replace that tubing. Granted, all these complications are less than 1%, but they are a known entity and they can happen.
It's a good procedure, and the weight loss isn't as good. We'll talk about some of the numbers here in a little bit, but the weight loss isn't as good, but we're very selective on who we decide to do what procedure we do.
And we arrive at that decision in concert with our patients. We don't push anyone in one direction. We try and arrive at the decision that's best for each individual patient.
And like Dr. Stallman said, the biggest thing is adjustability. We can affect weight loss based on whether we inflate or deflate the balloon. We talked about the potential complications.
How much weight can you lose with the lat band? Anywhere between 40 and 60% of your excess body weight. It's a little more delayed, comes off a little bit later than the bypass or the sleeve gastrectomy, but you do tend to lose 45 to 60% of your weight at about 1.5 years. That's the sweet spot. That's when patients really get cranking with their weight loss.
And the other thing we didn't mention about the band is it requires frequent visits to the surgeon to get filled or adjusted, either filled or deflated.
Every month.
So that's one thing to bear in mind.
This schematic will show the sleeve gastrectomy. It's where we simply staple off a large portion of the stomach, leaving a banana-shaped remnant. That portion of the stomach that was stapled off is actually removed and taken out of the body. Food goes down just like normal. We haven't rerouted anything. We've simply restricted the amount of food that's able to be taken in by making that stomach about 70-80% smaller than it was to start with. It's done through the exact same incisions as the lat band. The advantage is 65 to 75% of excess body weight is lost, and it's actually lost more rapidly than the lat band and about equivalently to the gastric bypass. In about 6-9 months, patients are really doing significantly better with their weight loss. It's, like I said, the same incisions. It's 1 hour operative time, so not much different than the lat band. The caveat is we do keep you overnight for 1 night in a short stay environment. The reason for that is kind of because of what are the potential complications of the sleeve. can have bleeding from the staple line, and you can have a leak from the staple line. Those are the two primary complications. The staple line is quite long. What we do to ensure that neither of those happen and give us our best chance of successful therapy is, at the time of operation, any place along the staple line that looks like it might bleed, we put little metal clips on, and then we spray a surgical super glue to help buttress it. And that also helps decrease the rate of a leak, because the super glue you're spraying kind of tends to get in the nooks and crannies of the staple lines and hopefully plug them up. Then we keep you without anything to eat or drink the night of surgery. The next morning we do a swallow study, which is an x-ray where you drink material and we watch it on x-ray. And as it goes down through that stomach, we're able to see if there's a leak or not. And national incidence of a leak is about 1%. We're doing pretty well on that front, significantly lower than that. And I think it's attributed to the fact that not only are we doing things together, but we're using these other additional adjuncts to try and help decrease that rate of leak.
The other thing, this is listed as a disadvantage, is that it's not reversible, but some people actually would see that as an advantage. And also the fact that, there are no foreign bodies like with the port, or with the lap band, the port and the band around the stomach. Not that it's not a good operation as well.
Has significantly less upkeep as well.
So, again, considering, what patient for what procedure, that's a personal decision, and decision that can be made with one of us when you talk to us. There are a lot of different things we kind of weigh into that, and we want to know. We're trying to figure out what your weight loss goals are. If you were young, not pediatric age, but young and wanted to get pregnant, that might be a good case to say, hey, maybe we'll do a band, because if you're going to get pregnant, we want you to be able to gain weight. We can deflate the balloon of the band and let you gain weight like you should in a healthy way.
The bottom line is it's a case-by-case basis. We meet with the patient and we decide together what is the best course of therapy. So,
recipes for success, and this is with any bariatric or weight loss surgical procedure, it boils down to, you don't want to drink your calories. You want to, Smoothie King, we've talked about this before, but Smoothie King is one of those things where you can drink a bunch of calories. Yeah, they're delicious. They can say, yeah, we'll throw some protein and some other things in with it, but you actually can drink a lot of calories, and you don't get that same sense of fullness, because that fluid will just slide right down. You'll never get that stretching on your pouch.
No matter what procedure you have done, whether it's the bypass, the sleeve, or the band, if you drink your calories, that's an easy way to cheat the system. And remember, at the outset, bariatric surgery is a tool to help you attain weight loss. And so there are going to be diet plans and everything that we go through to help optimize your weight loss. This is once again, the big hot button topic in today's day and age, diabetes and its relation to morbid obesity. We've always known that obese patients have a higher incidence of type 2 diabetes. There was a landmark study done just recently that showed cure rates of diabetes with bariatric surgery and the various procedures and how they've impacted it. The lap band has shown a 28% resolution of diabetes. The sleeve, 52%, and the gastric bypass, 62%. So doing nothing else other than having your procedure and having the weight loss from that, diabetes has gone away in this proportion of patients. Shown that not only is it excellent for weight loss and curing some other of the comorbidities, but significantly impacts diabetes.
So speaking of comorbidities, the different things like hyperlipidemia, that gets corrected in over 70% of patients. High blood pressure goes down in the same number of patients. Sleep apnea, the amount of tissue in the airway there, when that goes down, the sleep apnea tends to get cured as well.
Reflux, joint pain, all those things that we talked about in the outset tend to show excellent outcomes.
And with the decrease in the joint pain, patients are able to exercise and be more active.
And lose more weight as a byproduct.
And help maintain that weight loss.
So in conclusion, we know it's a chronic medical illness. We know that diet, exercise, and medications tend to not work, with showing 90 to 95% of weight regain at 5 years. Surgery is the only modality that's been shown to be effective for long-term weight reduction. And the best part is insurance coverage is improving. So 5 years ago, less than a quarter of insurance companies were paying for bariatric surgery. Now, about 60% of insurers are. That being said, there are ways to get this taken care of if your insurance doesn't cover it. There's alternate financing plans available nowadays. So accessibility to more patients is on the rise.